Hello everyone. Now we will move on to the second part of HIV. To recapitulate, you people are aware of the structure of HIV, that is the morphology of HIV. Now you know that it's a enveloped virus which has surface proteins, it has an RNA, two strands of single stranded RNA, and it has a reverse transcriptase. That is, you know the morphology of HIV virus, you know its important antigens, then you know how it multiplies and what is the pathogenesis of HIV infection in humans. Now we will move on to the clinical features of HIV. Natural course of HIV in most of the patients, that is 80 to 90% of people who are infected with HIV are typical progressors, means they undergo the natural course, which involves these 4 stages: acute retroviral syndrome, then there is a period of asymptomatic or latency period, then there is persistent generalized lymphadenopathy, followed by the 4th stage of HIV infection, which is AIDS related complex or acquired immunodeficiency syndrome. Following an infection with HIV, the virus is carried to lymph nodes where it multiplies and spills over into general circulation, leading to primary viremia. During this time, due to this primary viremia, suddenly there is a drop in CD4 cells because they come as a first line defense, and this happens after 3 to 6 weeks of primary infection, during which patients generally will have a myalgia or flu like symptoms. This settles down in a matter of 2 to 4 weeks, during which both the cell mediated immunity and humoral immunity come into action. Some specific or non-specific antibodies, neutralizing antibodies for HIV are produced by the HMI, and activated T lymphocytes are produced due to CMI. Here this time it is removed, the virus is removed from the general circulation and it multiplies only in the lymph nodes. This period of latency may extend from as less as 10 years to maximum 30 years. But this is a clinical latency, that is the patient will not have symptoms because there is no viremia. The virus is only in the lymphoid tissue, but it is not microbiological latency, means the virus is not microbiologically latent, means it is continuously undergoing multiplication. Only clinical features or symptoms are not there because there is no viremia. HIV antibody test is reactive during this phase and the person is definitely infectious. So this asymptomatic stage or period of latency, as long as 10 to 30 years the patient remains infectious. Only 5 to 10% do not develop AIDS even after 15 years, and they are called as non-progressors or long-term non-progressors. Otherwise, most of them will progress to a stage of AIDS after 15 years. So, after this period of latency, when the virus multiplies to such an extent that it can suppress the CMI, then it spills over into the general circulation. That time you come across the symptoms called as persistent generalized lymphadenopathy. Persistent, this lymphadenopathy means the enlarged lymph nodes. How much they should be enlarged? More than 1 centimeter. And generalized, it is more than 2 non-contiguous sites lymph nodes will be present, and definitely they are present for more than 3 months. Such a condition we call it as persistent generalized lymphadenopathy. Following PGL, there is once the patient moves on from PGL for more than 3 to 6 months, he has a persistent lymph nodes, enlarged lymph nodes, then he enters into a phase of AIDS or AIDS related complex. This is an end stage HIV infection wherein CD4 levels fall and viral load rises. This is characterized by the opportunistic infections due to fall in CD4. Once the CD4 levels have fallen, there will be drastic suppression of the cell mediated immunity, or cell mediated immunity cannot override the infection, and the HMI, that is a humoral immunity, is very non-specific. Non-specific antibodies are present, hence it cannot eliminate the infection, and CMI is suppressed due to reduced CD4 cells, so CMI cannot eliminate the infection. So due to both suppression of CMI and HMI, the viral load drastically increases and the patient becomes prone to opportunistic infections. Various opportunistic infections are seen in HIV. Some examples that I have mentioned here are parasitic infections like toxoplasmosis, cryptosporidiosis, isosporiasis and strongyloidosis. Fungal infections like infection with Pneumocystis jirovecii, candidiasis, again most common opportunistic infection is candidiasis, cryptococcosis, aspergillosis and histoplasmosis. Among the bacteria, please remember tuberculosis due to Mycobacterium tuberculosis or non-tubercular mycobacteria is the very common, or I should say commonest bacterial co-infection with HIV. Then there is salmonellosis, Campylobacter infection, actinomycete infection, legionellosis are also seen with HIV in people living with HIV. Among the viral infections, CMV and herpes simplex are very common. The malignancies associated with AIDS complex or in the last stage, end stage of HIV infections are the Kaposi sarcoma caused by HHV8 and lymphomas, Hodgkin's and non-Hodgkin's lymphomas. Now, clinical diagnosis. WHO in 2007 has staged clinical diagnosis of HIV into stage 1, 2, 3 and 4, wherein stage 1 is the asymptomatic stage and the persistent generalized lymphadenopathy. So, if you see a patient who is asymptomatic but positive for or reactive to the antibodies, or he has persistent generalized lymphadenopathy, he will be stage 1 of WHO classification, clinical classification. In the stage 2, WHO says patient may have unexplained moderate weight loss but less than 10% of the known weight, and recurrent respiratory infections, infection with herpes zoster, recurrent oral ulcers and pruritic eruptions, these all fall into stage 2. Then stage 3, when there is severe unexplained weight loss of more than 10%. Stage 2, I had told it is less than 10%. Now if the weight loss is more than 10% and it is unexplained, then you can think the patient is in stage 3 HIV. Then there may be unexplained chronic diarrhea of more than 1 month, persistent fever of more than 1 month, oral candidiasis, pulmonary tuberculosis, severe bacterial infections. All these are there, means patient is in stage 3 of WHO clinical classification. Stage 4 is called as the end stage HIV infection or HIV wasting syndrome, also called as slim disease, which is characterized by profound weight loss more than 10%, again there is weight loss, chronic diarrhea of more than 1 month, unexplained fever of more than 1 month, and all the or many of the opportunistic infections that I mentioned. This falls into stage 4 or end stage HIV infection by WHO classification of 2007. Now, so now you people are aware of what are the clinical symptoms. So invariably patient never comes to us in the period of initial flu because that is self-limiting. Then patient may not come to us even during asymptomatic stage. By chance HIV antibodies may be detected. For example, the patient is asymptomatic but it's a pregnant woman, so you do HIV testing as a part of ANC protocol and you happen to detect antibodies. Like that, even in the latency patients may not come to us. But when do patient comes to us? Patients will generally come when there are opportunistic infections or when there are there is unexplained weight loss or persistent diarrhea or persistent respiratory infection and persistent fever. That time, that is invariably the clinical stage 3 of WHO classification, patients come to us. Now, when do we do, how do we go about the lab diagnosis? The laboratory diagnosis of HIV can be classified by in specific tests and non-specific tests. Among the specific tests, we have to do screening tests, supplemental tests and confirmatory tests, and the non-specific tests, which they are not specific to HIV. So they are the other parameters which vary or which have changed in HIV infection. They are non-specific tests. So we will move on to the specific tests for HIV. Most commonest is the antibody detection because it is simplest and widest in its use. Antibodies may take 2 to 8 weeks or months for antibodies to appear after infection. During this period, so from the time of infection to the appearance of antibodies is called as window period. That time patient will be negative for antibodies and the infection can be detected only by the antigen testing by P24 antigen of ELISA or RNA RT-PCR or detection of DNA, pro-DNA of HIV virus. If you see this graph, you can see that immediately after infection, the P24 antigen rises and it falls by 4 weeks. So, that 4 weeks only P24 is detectable, IgG and IgM are not detectable. So, almost at the end of 3 weeks or beginning of 4th week, you can see IgM start increasing and 8 to 10 months it remains in circulation and falls. Then IgG, if you see, has increased by around 5 months. So, starts production, the IgG increases, is seen in the circulation by around 5th to 6th month and goes on increasing and remains in circulation for a long period of time. Now, this is a chart which shows, you can see here that around from 6 months, 6 to 8 months to 36 months, that is around 3 years latency is there, during which the virus, the patient may not have any symptoms or may have only lymphadenopathy. And you can see AIDS related complex from say around 36 months to about 65 or 60 months. So, around 5 years there may be AIDS related complexes. Then you see the stage of AIDS, that is acute acquired immunodeficiency syndrome. Then if you see the yellow line which shows P24 antigen is very high during the acute infection, but antibodies are not there. So, the screening tests may be negative, but P24 antigen detection will definitely be positive in this window period. Now, this screening tests, I told, they are the most widely used because they are easy to perform, they are highly sensitive and specific, but they need confirmation. With what do we confirm? We can confirm with supplemental tests. The most commonly used supplemental test is the Western blot test, wherein the proteins of HIV, that is our GP120, GP41, P24, P18, P55, all of them are separated by electrophoresis and they are blotted onto a strip of nitrocellulose paper. These strips are available commercially. When we add the patient serum suspected of HIV, if the serum has antibody, it will bind to the antigen present on this strip and a prominent color is produced. Now, look at this. This is a HIV Western blot strip. You can see the broad bands. They are the bands formed due to the reaction of antigen and antibody. That means the patient has antibodies which will go and bind to these antigens which are impregnated or blotted onto this nitrocellulose strip. Now, as per WHO, presence of at least 2 envelope bands with or without a gag or Paul band, we consider it as positive for HIV or confirmed HIV infection. CDC criteria says presence of any 2 out of P24, GP120, 160 or 41, any 2 bands, if they are present, it is confirmed HIV infection. Alright. Yeah. This is the Western blot strip. Now, the other confirmatory tests. Now you have to, if you have found antibodies and you want to confirm, you have to detect the antigen. And the most commonly used antigen test is P24 antigen because it is earliest to be present or earliest viral marker and it is detectable throughout the infection. P24 antigen can be detected by capture ELISA and P24 HIV ELISA can work even in the window period of the HIV infection when the antibodies are negative. Now, culture, though not the diagnostic method, it is not used for diagnosis, used only and only for research. The culture of HIV virus is done by co-cultivation method. Co-cultivation means virus, the blood from the patient is incubated along with normal lymphocytes in presence of interleukin 2. If the normal lymphocytes are infected by this patient sample, then we will detect for presence of P24 antigen or reverse transcriptase activity in the culture filtrate. This is how the co-cultivation, that is the patient sample is cultivated along with normal lymphocytes and seen for presence of virus or infection of the normal lymphocytes with the virus and its reverse transcriptase activity. Let me tell you again, culture is not the modality for diagnosis, it is only used for research purposes. Then the gold standard is PCR detection of the RNA. RNA can be detected by real-time PCR, that is RNA PCR. If it is real time, you can also see the number of copies. So the exact number of copies which are being taking place in the host can be tested by the real-time RNA PCR, or we can also use proviral DNA detection. This also is a confirmatory test. Now these were all the specific tests. So specific tests we are going to see for presence of antibodies or presence of antigen. Confirmation is by PCR, by confirming the P24 antigen invariably, or DNA also we can confirm, or the Western blot test. Now coming to the non-specific tests, that is the other non-specific parameters that are variable in the HIV infection. Now what happens to the leukocyte count? There may be leukopenia, and specifically it will show lymphocytopenia, and CD4 to CD8 cell ratio is reversed. Also we can see thrombocytopenia. These are the non-specific tests for HIV. Now strategies for HIV. Now as per the National AIDS Control Organization, it has developed the various strategies, strategy 1, 2 and 3. Strategy 1 is only for blood banks, that is if any patient or any person wants to be a blood donor, he has to have the he has to satisfy the strategy 1. In the strategy 1, one kit only is used. If he is positive by that kit, he is considered positive. Negative, he is considered negative. In strategy 2, which is done for surveillance of AIDS, here two test kits with different principles have to be used. First, if a patient comes positive by a first kit, then he has to be subjected, the sample is subjected to the second kit. If it is positive by the second as well, then he is considered or reported as positive. If it is negative by the second kit, then equivocal result or repeat of the testing is done. That is strategy 2. Then strategy 3 is for diagnosis. In strategy 3, 3 kits with 3 different principles have to be used. Now if they use the first kit and the patient and the sample comes negative, it is reported as negative. If it is positive, then it is subjected to a second test with a different principle. If it is positive in both, that is first and second test, it is subjected to a third test. And if it is positive by third also, then it is given as positive test and will require a post-test counseling. The patient will require a post-test counseling. If in the third test, that is the patient is positive by first and second test and is negative in the third test, he is called as indeterminate test and a repeat testing has to be done. If the patient is positive by the first test kit and negative by second test kit, then also we do a third test kit, and if he is positive by third test kit, he is called as indeterminate, and it is negative by third test kit, then he is called as negative. Okay, this is how the strategy is followed by NACO guidelines. Now, prophylaxis for HIV. Health education, as you all know, is most important because the modes of transmission, the risk activities, everything, if an education is given, lot of HIV infection can be prevented since we do not have a specific vaccine available. And As a part of prophylaxis of HIV, mandatory screening of blood and blood products is performed at all the blood banks. Then to prevent the parent to child transmission, we have PPTCT, wherein the couple undergoes a counseling pre-test. After then they give the sample, and after test also, that is post test counseling also is done. And if you come across people who are living with HIV, then treatment of opportunistic infections along with counseling is required, and they are put on the antiretroviral therapy. Other ways to prevent HIV infection are needle stick injuries, using the appropriate personal protective equipments, and following the universal precautions, assuming all the samples are infectious. And in spite of all this, if somebody, a healthcare worker, say for example a healthcare worker becomes positive for HIV, becomes exposed to HIV, he has to take the post exposure prophylaxis. Thank you.